Okay, here we are back with part 2 of chapter 29, talking about psychiatric emergencies. In this last part of chapter 29, we're going to look at more specifically some of the specific issues that we're going to deal with in the field when it comes to psychiatric emergencies. The first one of these is acute psychosis. Acute psychosis is a state of delusion where a person loses touch with reality. This can be triggered by various causes, including things like substance abuse, environmental stressors, or even other types of mental illness. Episodes of acute psychosis can either be short-lived or long-term. Common signs are going to include some disorganized thoughts and some disorientation. When we assess them, we're going to find that they have profound thought disorders because this is kind of the hallmark of the symptoms that we'll see. A full assessment is often not possible due to the patient's mental state. And of course, the goal is for safe transport without causing any further harm. So we want to keep them calm. And we'll use that cost map framework that we talked about in part 1 to help identify some of the common symptoms and maybe drill down to get a little better idea of what's going on with them. So with our assessment approach to acute psychosis, we're going to evaluate the patient's level of alertness and responsiveness. We'll check for if the patient knows who they are, where they are, what's going on, the activity. We'll observe the patient's movements and level of physical agitation or lethargy. We'll note the rate and volume of their coherence and relevance of speech, and assess the clarity of logic and thought. Are they having organized thought processes? We'll try to evaluate short versus long-term memory and identify the patient's emotional expression, and then watch for those signs of hallucinations. This is that whole cost map that we talked about in part 1. This is what we're going to do for these psychotic patients. Standard reasoning may not work with these patients because these patients often have their own internal logic that none of us are privy to. It's normal to feel uneasy around someone in a psychotic state, but don't ignore that uneasy feeling that you get. Realize that these disorganized patients, in all the disorganization for them, what's really helpful for them is to have some structure. So make sure you speak clearly and simply. You give firm, consistent instructions. Don't contradict yourself. And then gently orient the patient to time, place, and the people around them. If the patient poses a danger to themselves or others, of course, you're going to have to take necessary steps to ensure your safety and the safety of others. Be sure to try non-pharmacological methods first, as many patients are going to resist treatment because of their fear of a lot of the side effects that some of the medications in their past has caused. If those fail, of course, we're going to have to look at restraining the patient if safety is an issue. We may have to administer some sort of a medication to kind of, sedate them or chemically restrain them. And of course, we need to make sure that we always follow the standing orders or talk to medical control about any of those medication decisions with these patients. Delirium is a sudden short-term decline in cognitive function. Unlike dementia, which is a chronic condition affecting memory and judgment, delirium comes on quickly. It can lead to agitation or violent behavior in some patients. Excited delirium is a dangerous state of extreme agitation and can actually be fatal. Agitated delirium, on the other hand, shows similar signs, but is usually used when the outcome is not fatal. So when we're assessing the delirium patient, try to calmly orient the patient to their surroundings. Use simple questions to evaluate their thinking and awareness, and perform a full assessment to check for underlying causes, such as sepsis or things such as that may not be quite so obvious. Law enforcement may be needed if the patient becomes violent or unmanageable. Try to identify the cause. whether it's a stressor or a medical issue, and this is going to help guide your treatment for that patient. Suicidal ideation is, we often run into these patients, and they wind up displaying some kind of unwillful or some kind of willful act designed to end their own life. And this here shows kind of a table of some of the risk factors that are commonly associated with suicidal ideation. When we're assessing these patients, we always want to evaluate the suicide risk, especially if we have a patient that is experiencing depression or severe depression. Paramedics may hesitate to ask questions about suicidal thoughts, but most patients feel relieved when somebody asks them, so don't hold back on asking them about suicidal thoughts that they may have. Use a stepwise approach to introduce the topic, and high-risk patients include those with prior attempts, those that maybe have concrete plans, or even a family history of suicide. These patients should be considered at a much higher risk because they are most likely to follow through. When we're managing these patients, it's important to never leave them alone, never walk away from them, especially if they are in their own environment, because we just don't know what they might have access to. Should remove any objects that could be used for self-harm. Again, if they're in their environment, they're going to know where those things are hidden, especially guns or knives or those kinds of things. Acknowledge and validate the patient's emotions, and encourage the patients to accept transport for further care. Now, oftentimes we're called and we have to intervene in those instances where there's violence, abuse, or even neglect. When we talk about abuse and neglect, we need to make sure that we assess the patient, the environment, and everyone else involved. So we want to get a big picture about what's going on, and then document all of our observations thoroughly, and of course report any concerns that we have to local authorities or those that would have oversight of that, especially in those instances where we're bound by law to do so. It's really important to even document the seemingly insignificant things that we notice at the scene, or those little things that kind of seem out of place, because a trained eye, someone that's trained in violence, abuse, and neglect, might read those, and it may be a bigger indication for them about what is going on. So what you observe, it's really important to document. With violence, most angry patients can be calmed by a confident, trained provider. So patients that are angry, don't reciprocate their language, behavior, their heightened emotional response. Stay calm, cool, collective, and that's going to kind of begin to diffuse them. Give them a little bit of space and encourage them to talk. Hear them out. Just because you're encouraging them to talk doesn't necessarily mean that you're agreeing with everything that they say, but you should encourage them to talk. It's going to help them to talk. And of course, always be ready to respond to an escalating sense of hostility or violence. And what I mean by that, know where your exits are, know how to back out of there. If you involve law enforcement too early with these particular patients, oftentimes it'll have a negative effect. So you want to be cautious about how you involve law enforcement with these patients. I'm not saying don't involve law enforcement. You absolutely may need to, but you may want to kind of gradually bring them into the picture, or more as a last ditch effort. So it's important for us to identify situations where there's a potential for violence. So you should be mentally prepared for a potential violent situation. So think it through whenever you're entering any call or any situation. There's always the possibility that violence is right around the corner. Don't rely solely on the dispatcher's information. Just because they told you a particular thing on the radio doesn't mean that it's 100% true. So pay attention to those things that you're seeing around you, or those gut feelings that you have about something being out of place. Stay aware of your surroundings and the situation at all times. You should maintain good, solid situational awareness and always know where the closest exit is and how you can get out of a particular situation. There are certain risk factors that make violence more of a possibility, such as situations that increase, such as situations that involve alcohol or drug use, or incidents involving large crowds, and as well as situations where violence has already occurred. So those situations, we need to have a heightened sense of awareness that things could go south. People who may be at higher risk for violence include those who are intoxicated, those experiencing psychosis, or those undergoing withdrawal or delirium. These people may be at risk for violence upon them because of the people around them not understanding what's going on with them. So they may be attacked because of what they're saying or the way that they're behaving that seems threatening to somebody else. So it's not just the patient that may be a threat to responding personnel, but the public that may be a threat to a patient that's in need of help because they don't understand what's going on with that person. Some warning signs of impending violent behavior in our patients would be the way that a patient may sit, or they may have a tense, sitting tensely or signaling some form of agitation. Their speech may be a giveaway. If they're speaking loudly or threatening, it's an indication that violence may be imminent. A patient may not be able to sit still, or they may be startled easily. They may be pacing the floor, or somebody else walks in the room and it kind of sets them off, and they're yelling, who's that? Why are they here? Those kinds of things. Nonverbal cues such as clenched fists and the avoidance of eye contact. So pay really close attention to your own sense of unease or discomfort, as this may indicate a heightened risk of violence that it may occur. I always advise EMTs and paramedics to always pay very close attention to, their spidey senses, or that gut feeling that things just don't feel right. They feel out of sorts. And anytime that gut feeling gets to a point to where that you're like, okay, I think this is getting out of hand, you need to know when to back out, when to, begin to remove yourself from the situation, and when you need to involve, those that are, trained to be able to handle that, or at least have the things needed to bring that situation to a peaceful end. So when we're managing a violent patient, we want to make sure that we have a full understanding in the context of all the potential risks involved. So know your surroundings, know where you're at. If you're not in your own surroundings, it's impossible to know everything that is available for that person to use against you. Make sure you watch for any of hazards that may be available or those kinds of things, and know your escape routes. Maintain a safe distance to minimize personal risk, and try those verbal interventions to de-escalate the situation. Remember, your calm, cool, collective voice is going to go a lot farther to de-escalate a situation. You're never going to de-escalate a situation by reciprocating loud voices and loud words with your own loud voice and loud words. It's never ever going to calm the situation down. It's just going to make it worse. So there are some mood disorders that we typically deal with in the pre-hospital setting. These were formerly known as affective disorders, but these are going to include things like manic depressive illnesses, major depression, unipolar mood disorders, where mood remains at only one pole of the depressive scale, or mania continuum, so it's going to stay on one side of that. And then of course we're going to have these bipolar, where mood alternates between mania and depression, kind of back and forth on a different kind of continuum. Now, that's not going to be the same for every patient, but it does switch. So manic behavior, these patients typically experience an exaggerated sense of happiness, joy, or euphoria, accompanied by hyperactivity and insomnia. They're usually awake and alert and easily distracted. The characteristic of mania behavior includes talkativeness, flight of ideas, such as a rapid shifting of thoughts, delusions of grandeur, elated affect, which is the hallmark of mania. And on the other side, we'll have the depressive side of it, where all that goes away. And these depression episodes may occur with a sudden onset and a limited duration before they go back into the mania if they have manic depressive. The onset of depressive episodes can also be subtle and chronic, as seen in the dysmithic disorder. Sorry about that. Some of these words are tongue twisters. For diagnostic features of depression, use the mnemonic gas pipes. So when we're trying to determine whether or not somebody is depressed, we're going to use this mnemonic called gas pipes. So are they experiencing things like guilt, self-reproach? Is their appetite abnormal? Are they having sleep disturbances? Do they have trouble paying attention? Have they lost interest in things that normally interest them? They might experience some psychomotor abnormalities, low energy, and even suicidal thoughts. Digging down into these a little bit will give you a better idea of whether or not they're suffering from depression. Schizophrenia. Schizophrenia, typically the onset of that is in early adulthood, like in the 20s to 30s. With schizophrenia, the patient will begin to experience things like delusions, hallucinations, a flat affect, lack of interest in pleasurable things, erratic speech, overly emotional responses, and the lack of or extreme motor behavior. So these patients kind of go the gambit, and it's like they're constantly kind of stuck out in left field. Their thought processes, what they're seeing and what they're hearing, are not really there. Nobody else is seeing that. Neurotic disorders refer to a group of psychiatric conditions that do not involve psychosis. So these are, generalized anxiety disorder, phobias, and panic disorders kind of fit into this category. Generalized anxiety disorders, where the patient experiences excessive worry about everything, even without clear reason, or they're unable to decide how to handle an upcoming situation due to their constant worry. The worry is difficult to control. It's hard to turn off. When caring for a patient with general anxiety disorder, introduce yourself calmly and confidently, listen carefully to the patient, and engage in general conversation about their feelings. Phobias, on the other hand, these are characterized by an intense, irrational fear or dread of a specific situation or object. When faced with the feared object or situation, the person experiences overwhelming anxiety. Although they usually recognize that their fear is irrational, it's really hard to put it aside. When managing a patient with a phobia, clearly explain each step of the treatment process before proceeding. That way they have a clear understanding of what's going on. Panic disorder patients are difficult to deal with at times. Panic disorder is marked by sudden or intense feelings of fear or dread, often occurring unexpectedly and for no apparent reason. If left untreated, attacks can severely limit a person's lifestyle. Many symptoms are the result of an autonomic nervous system activation. Symptoms usually peak within about 10 minutes, but attacks can last up to an hour. And remember, a panic attack can mimic various physical conditions due to its symptoms that it creates. So realize this panic disorder, most important kind of thing to take away from this is it's typically the result of some other stimulation of the autonomic nervous system or a depression of one side of the the parasympathetic side of the autonomic nervous system. So it can be medication induced, or some other disorder induced, part of the autonomic nervous system. This table refers to some of the signs and symptoms that we typically will see with a panic attack. So we'll see quite a few things, but typically you can see it becomes pretty clear what's going on with them. Oftentimes these patients know what's going on and they'll be able to tell you that, hey, I'm having a panic attack. If it's their very first panic attack, they may not know that. Making them breathe into a paper bag and that kind of stuff because they're having hyperventilation symptoms is not a good idea, so we don't do that. Because it's not an effective way to treat it. So when you're dealing with panic disorders, when you arrive at the scene, it's really helpful to separate the patient from other bystanders, because other bystanders may be panicked themselves and causing the patient to panic a little bit more. Create a calm, quiet environment. Be patient with the patient's distress. Let it subside. Help them breathe their way through it. Reassure the patient that they're safe. Identify and name the patient's symptoms that they're having, and assist the patient with regaining the control that they want to have. So it takes a little bit of time. Work your way through that. Sometimes those patients know how to do that a lot on their own, and they'll start working through that. There are some substance abuse related disorders. We've talked about a lot of these in chapter 28. But there's some substance-related disorders and addictive behaviors. And these are categorized into 4 levels. It's either substance use, substance intoxication, substance use disorder, or substance dependence. An integrative approach is necessary to determine the most effective course of treatment for these patients when we come across them. So, eating disorders, on the other hand, there's a couple of those that we from time to time may be confronted or face. Of course, that's bulimia and anorexia. These disorders can lead to severe electrolyte and nutritional imbalances. They also can cause anxiety, depression, substance abuse disorders, and those types of things, because those are commonly present with patients that are suffering from bulimia or anorexia. These patients have a skewed view of themselves where they see themselves as much heavier, even though they may be very, very thin and malnourished. They still see themselves as overweight. Bulimia is characterized by consumption of large amounts of food, and then they counteract this by purging that food, such as making themselves vomit or doing excessive exercise. Anorexia, on the other hand, is severe weight loss that threatens the patient's health and life. The patients exert extreme control over their food consumption to prevent themselves from gaining weight. Both of these lead to serious nutritional imbalances and malnourishment, and if untreated, can lead to death. There's been many people that have died from both bulimia and anorexia because they wasn't caught soon enough and treated. Somatoform disorders involves a preoccupation with the physical health and appearance. Hypochondriasis is an anxiety or fear about having a serious disease despite medical reassurance. So hypochondriac. So in spite of everybody saying you're fine and nothing going on, they still have that fear or anxiety about it. Conversion disorder is a physical condition that results from psychological stress, where the person may fake or experience physical symptoms without any underlying medical cause. Where we see this is you read about some new disease or disorder, and then all of a sudden you begin to convince yourself that you have that, and then you begin to start to experience some of the signs and symptoms of that disorder, when the reality of it is you don't have it at all. It's purely psychological, that's where that's coming from, the basis of that. Factitious disorders, like Munchausen syndrome, this is where the patient intentionally produces or feigns physical or psychological symptoms in order to get sympathy. And of course, then you can have a fastidious disorder by proxy or Munchausen by proxy. This is where a patient or a caregiver intentionally makes their child or family member ill in an attempt to gain attention and sympathy from others. This disorder is considered an atypical form of child abuse. It's child abuse, but it's an atypical form. We see the Munchausen by proxy a little more often than we see Munchausen. And perhaps that is because the true Munchausen syndrome is a little bit tougher to kind of sort out, whereas Munchausen by proxy, when it's discovered, it typically makes the newspapers, and probably not the newspapers anymore, but it makes the news, and we hear about that a whole lot more versus a typical just Munchausen syndrome. Impulse control disorders involve the inability to resist a temptation or an urge. Examples are going to be something like intermittent explosive disorder, kleptomania, pyromania, pathologic gambling. And of course, these disorders are relatively rare. They're not really common types of disorders that people have. Personality disorders, these involve dysfunctional ways of relating to others or cause distress to those around the patient. Another psychiatric condition is often present simultaneously with these disorders. Patients with personality disorders often struggle with treatment, and it's important to stay calm and professional when interacting with these patients. Medications for psychiatric disorder and behavioral emergencies. There are several types of antipsychotic psychotropic medications out there. These drugs are typically designed to affect mood, thought, or behavior. Patients may be on multiple psychotropic medications when we encounter them, so it's important to identify which medications have been prescribed and when they were last taken, because that might have an impact on what's going on in the current situation. Different medication types that they may be on. One of them is antidepressants, which are used to treat symptoms of depressive illness. They alter the neurotransmitter levels in the autonomic nervous system. Remember, we talked about those quite a bit in chapter 28. SSRIs like Celexa are the most commonly prescribed, but then there's some MAOIs that are recommended for atypical major depressive episodes and specific cases of refractory major depression and panic disorders. So we might see them on a variety. It's not unusual to see them on more than one as well. Benzodiazepines are prescribed for severe emotional distress. These are short-term use, typically for short-term use in order to help manage anxiety and acute panic reactions during crisis. So that's typically when we'll see these being used. So the patient may actually be under the influence of this when we get there. Antipsychotics, there's some newer atypical antipsychotic drugs that have a lower risk of adverse effects and seem to be more effective. Biggest problem with some of the older antipsychotics, which led to non-compliance with patients, was the side effects were just not desirable, which led to patients being non-compliant with those medications. What these do is they try to help relieve some of the delusions and hallucinations that a patient may be experiencing. These patients can also improve symptoms of anxiety and depression along the way as well. However, some of them, they still have some side effects, but the newer ones, like you say, are not quite as bad as some of the older ones. So side effects we typically see can be metabolic, cardiovascular, and maybe even some acute dystonic reactions. And up to and including some even atropine-like side effects. This table here on this page 29A lists some of the antipsychotic medications that are out there that are commonly used. It's impossible to remember them all because sure enough, you get some of them memorized and they come out with new ones. So it's always good to, to look these up, look these medications up, either, on your phone or through a field guide or that kind of thing to, determine where they fit into the bigger picture. Amphetamines, these are central nervous system and peripheral nervous system stimulants. They're used to treat attention deficit disorders with hyperactivity and narcolepsy. These can raise the systolic and diastolic blood pressures of patients. So that's something that we'll need to be aware of, especially if they've taken too much of one of those. It could be problematic. The effects these medications have is going to be dependent on dose, the mental state of the patient, and generally the personality of the patient. Some effects may include increased alertness, reduced sense of fatigue, elevated mood, increased concentration, maybe even euphoria and increased motor and speech activities. So we often get called to in situations where there's a non-compliance with medications. And the common reasons why patients become non-compliant or they stop taking their medications is, a big one is it kind of dulls their senses and it slows down their thinking. Those are two of the biggest reasons why. And the third reason why is the cost of medications. If they don't have insurance or their insurance doesn't cover it well, it's too expensive. So that's when they start, kind of changing their own dosing, taking a half a pill or taking it every other day or every third day. And eventually that begins to catch up with them. When this happens, when they stop taking this, it really increases the likelihood that their mental illness will return and they may even commit a violent act. So we need to inquire about previously prescribed medications as well as missed doses. How well have they been taking their medications? So it may be indicated in an escalating behavior crisis that we use emergency medications. The potential danger is too great to not intervene in these cases, so we're going to have to do something. So prior to administering chemical restraints, we need to make sure that we assess and thoroughly understand the chief complaint of what's going on. We need to know definitively if they're allergic to anything, get a good medical history, and then make sure we know what medications they're currently taking so we don't have any interactions there, and then weigh the risks versus benefit, risk versus reward here for using chemical restraints or medications to manage the crisis. And the last topic that we're going to talk about is the psychological effects of war, and more specifically returning combat veterans. But we could kind of categorize some other people in here, up to and including medics that have experienced some things, and nurses, that have experienced some traumatic events. But in 1980, the third edition of the Diagnostic and Statistical Manual for Mental Disorders introduced the concept of traumatic stressful events outside of an individual's control that can lead to psychological trauma. Prior to this, it was pretty much called things like shell shock or, combat fatigue and those kinds of things. It wasn't invented in 1980. It had been around for a long time before that. This was the first time that they began to more closely correlate those stressful events with the current psychological state of someone. Some events that could cause this psychological trauma, especially, with military personnel. Those that have experienced combat had a much higher incidence of post-traumatic stress disorder. The symptoms of post-traumatic stress are going to vary in severity, but are usually based in 4 categories. They'll have these intrusive thoughts. They try to avoid reminders of that particular event. That's why they don't typically talk about them or put themselves in situations that might be similar to those that, created that memory for them. They'll have negative thoughts and feelings. And and they're very reactive to some symptoms. They'll have this arousal and reactive symptoms whenever that occurs. Almost a true fight or flight, panic mode that sometimes happens to them. People experiencing intense distress often develop symptoms within days of the event. Symptoms differ from those of PTSD, the acute distress disorder, and with acute distress disorders, they differ from PTSD in that they are dissociative symptoms, but they're considered a precursor to PTSD. So we will see this acute stress disorder kind of come in immediately following and can lead to PTSD. When we're encountering military service members with medical or behavioral issues, it's important that we use compassion, understanding, and that we're respectful. We follow our protocols, but also be aware of the cultural background of that patient and how that may play a role into, how they've responded to this stress up until that point, and whether or not they've sought treatment. Again, this kind of focuses on those military personnel, but realize it's very likely that we could encounter, children, adults, non-military personnel that are suffering from very similar symptoms based on their experiences too, which could include something that was very much like a war zone, maybe a mass casualty or a mass shooting incident, or those types of things. And this will also affect doctors, nurses, medics, and that kind of thing as well. So be aware that can be a part of it. And oftentimes these patients seek to self-medicate too, so can further cause other issues that we may encounter as well. Okay, so that is the wonderful chapter 29, and I believe this is going to wrap up the medical section of your textbook. So we're done with medical. We will see you guys back in chapter 30. See you soon.